I'm Dean Whiting from Pathology Technology Australia, and today I'd like to talk briefly about rapid antigen tests for COVID-19. Now, these have been much in the news lately, talking about how these tests could be used in many situations across Australia. And there's also been some news about their limitations. So I'd like to talk that through today. Rapid antigen tests are based on lateral flow immunoassay technology that's been around for about 20 years. These are very, very simple devices. You may have seen them in the pharmacy for doing pregnancy tests. And you may be able to see on this one a little line across where it says C. So this is a test which has been done, and it's a negative test, and the C line is the control line. If this was a positive, you would see a line at the T mark, which is the test mark. So these tests can be done almost anywhere by anybody who's been trained, and they'll give you a result in 10 to 15 minutes. They do require a swab, either from the back of the nose or throat, or from the near nasal surfaces. In many parts of the world, but not yet in Australia, these tests are done at home. By school kids, by people before they go to work, by people who are just feeling a bit off for the day and want to make sure that they're not going to transmit COVID into the workplace. We're hopeful that maybe that will become the case in Australia as well, that we may be able to do these tests at home. So some of the criticism of these tests is that they may have quite a high false positive rate. Now, what does that mean? False positives means that the test shows up as a positive when the person doesn't really have COVID. And clearly this could be quite nerve-wracking for somebody who does have a false positive. But from a public health perspective, this is not really of huge consequence unless the false positives occur at a large number. And in fact, in real-world studies around the world and in Australia as well, the false positive rate of these tests is incredibly low. For example, these tests were run for about 7 months at Howard Springs, our quarantine station just out of Darwin, and they found a false positive rate of about 1 in 10,000. And this is commonly found with these tests almost wherever they're done. So the false positive rate is not really a concern. The second criticism raised against these tests is that they have a false negative rate, which means that you see a negative result when a person actually has COVID-19. Now, clearly, this could be quite a serious circumstance. But when you look at where these tests are done and why they're done, it actually becomes a non-issue. Recently in Australia, these tests have been done in clients attending various workplaces or services. And these clients would not normally have been tested for COVID-19 because they have no symptoms. But attending important workplaces, in certain circumstances, these have detected people who would never have been detected otherwise. The positivity rate, or the true positive rate of these tests, is around the 95 to 97% mark when the viral load in a person is high enough to be transmitted, or when they are in their first 7 to 10 days of an infection. So when you apply these tests in circumstances where the regular PCR test is probably not being done, or a person wouldn't normally have gone for a PCR test, you're going to pick up about 95 to 97 out of 100 cases. These are cases that would never have been picked up otherwise. So that's one important application of these tests. The second, and probably the most crucial application of these tests, is in repeat testing of at-risk cohorts. What do we mean by this? So people who are at risk of contracting COVID, such as hotel quarantine workers, such as people who work in COVID wards, people who work close together who can't socially distance, people who work in aged care, people who work in essential services such as food processing and transport. These people could be tested on repeat testing, and the recommendations, and certainly the literature supports testing every 3 days or so. And when you do this, the studies have found that this testing is the same accuracy then as PCR testing. So testing of at-risk cohorts of essential workers every 3 days would be, with a rapid antigen test, would be as accurate as testing with PCR. The benefit, of course, is that you get a result immediately and you can take action immediately. In fact, the World Health Organization recommends that in circumstances where community transmission of COVID is so high that you can't keep up with it with PCR, or where PCR is not available, the rapid antigen tests are then recommended. And this is the situation that we're finding now in Australia, especially in New South Wales and Victoria, where the community transmission rate is really relatively high. So these tests could be used, for example, for essential workers in the morning before they head out to go to work, and then they could have the confidence that they're not infected and they can safely go to work without the risk of transmitting amongst their workmates, or knowing that they're not transmitting amongst their community or their home. The third criticism that's often rendered to rapid antigen tests is the lack of accountability around the performance of the test and also around the information management. What do we do with the results? And even this problem has now been solved with some very clever mobile phone technology, with which you can take a picture of yourself with the test strip. You can take a picture of yourself taking the swab. And you could be supervised online, for example, or supervised in a workplace while you collect the sample and do the test. So even the problem of managing the data and supervising testing is now largely taken care of. I'm told that in Australia, we're the only OECD country now not extensively using rapid antigen tests. And I suspect really the time now is right to pivot to do these tests, to start to become accustomed to how these tests work, to start then to think about how we roll these tests out in the home for home testing, and to develop a culture of testing ourselves for seasonal flu, for a cold, for exactly this purpose, the next pandemic, for example. So if we become accustomed to doing this testing at home ourselves, we could potentially reduce the transmission of seasonal flu, of colds, and of the next pandemic when it comes around. On average, we have a major respiratory epidemic every 7 years. So this would be an investment really well worth making. So I hope that's been helpful. I'm Dean Whiting, Pathology Technology Australia.